Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled The Role of CDC and AFM Surveillance. My name is Gigi DeFibri, and I will be moderating this podcast along with Rebecca Whitney. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download and via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Janell Routh, Dr. Manisha Patel, and Dr. Benjamin Greenberg. Rebecca.
Dr. Janell Routh graduated from the UCSF UC Berkeley Joint Medical Program in 2004 and UCSF Pediatric Residency Program in 2007. For the next 3 years, she practiced pediatric HIV and general tropical medicine in Malawi with the Baylor International Pediatric AIDS Initiative. She returned to the U.S. to start the Epidemic Intelligence Service Fellowship with CDC in Atlanta in 2010. Her CDC experience has spanned food and waterborne outbreaks, cholera prevention in Haiti, to her current work in the Division of Viral Diseases as the program lead for Acute Flaccid Myelitis since 2016. Dr. Manisha Patel is a medical officer with the U.S. Centers for Disease Control and Prevention. She is the epidemiology team lead in the Division of Viral Diseases and oversees 8 domestic viral programs, specifically measles, mumps, rubella, polio, acute flaccid myelitis, varicella, zoster, and cytomegalovirus. She maintains expertise in the epidemiology and immunology of viral vaccine preventable diseases, which includes domestic surveillance, outbreak response and control, vaccine policy, and health communications. She provides care to pediatric patients at the Children's Hospital of Atlanta.
Thanks, Rebecca. And Dr. Benjamin Greenberg received his Bachelor of Arts degree from Johns Hopkins University and his master's degree in molecular microbiology and immunology from the Johns Hopkins School of Public Health in Baltimore, Maryland. He completed his residency in neurology at the Johns Hopkins Hospital and then joined the faculty within the Division of Neuroimmunology. In January of 2009, he was recruited to the faculty at the University of Texas Southwestern Medical Center, where he was named Deputy Director of the Multiple Sclerosis Program and Director of the new Transverse Myelitis and Neuromyelitis Optica Program. Dr. Greenberg is recognized internationally as an expert in rare autoimmune disorders of the central nervous system. His research interests are in both the diagnosis and treatment of transverse myelitis, neuromyelitis optica, encephalitis, multiple sclerosis, and infections of the central nervous system. He currently serves as Director of the Neurosciences Clinical Research Center and is a Kane Denius Foundation Scholar. Welcome, and thank you all for joining us today.
Thanks.
So to start, I'd like to pose the first question to Dr. Patel. The early response by CDC to AFM was controversial for some parents. Would you like to comment about this?
And actually, before Dr. Patel chimes in, if it's okay, Gigi, I may just step in and make a comment. So, and I'm very interested to hear Dr. Patel's assessment, but as having worked on this for the last over 5 years and worked with a lot of parents and families who've been affected by AFM and a lot of clinicians and researchers, I want to put the question into a bit of context if I can, because I think there has been a large amount of frustration nationally on getting a handle on this entity in its entirety. And as I've gotten to work more closely with colleagues such as Dr. Patel and Dr. Routh at the CDC, I've had a perspective on what we nationally have done right and what we might have done better over time, but I've learned a lot relative to the CDC in particular. And I think a lot of the frustration early on came in a couple different flavors. One was around publicly ascribing causation, and we'll talk about that during the podcast of what's causing AFM, recommendations around treatment, and then resource investments and surveillance. And as I've come to learn much more than I ever did about our public health system in the United States, it's become pretty clear to me that there is a huge need to invest much more seriously as a nation in what we're doing from a public health perspective. The CDC's mission, which is to protect all of us from a whole host of different conditions, is being pursued on a significantly under-resourced budget. The individuals I've worked with there have been incredibly dedicated, gifted individuals, but are part of a process that integrates a national public health system with over 50 different states that have local and state level public health agencies that have to be involved at every step of the way. And so as we as a nation have not, I would say, nimbly responded to every public health issue that comes up, I actually think it's impossible based on the way we are resourced. I think the group we have working are incredibly talented and dedicated folks, but if you listened to the introduction, Dr. Patel is simultaneously overseeing AFM, measles, and about 6 other things that I didn't know were on her plate. And so as we try to, I thought I was busy, as we try to get a handle on things like AFM relative to a national level, I think we have to recognize we all have different roles to play. And one of the things I've come to learn about the CDC is the initial caution that was exercised in some respects around ascribing etiologies comes from a balanced view of not simultaneously wanting to be aggressive at getting at an answer, but not prematurely or incorrecting ascribing causation. The official statements of the CDC and I have not always agreed, and that's okay. I think where we've gotten to today is very clear alignment on the science and the needs and the commitment to doing the work that needs to be done for this. So before Dr. Patel went through the timeline, I just wanted to jump in and offer that, because I know the parents and the clinicians have shared frustration over the years, and rightfully so, but I think we need to be very cautious with emotionally assigning blame when in reality part of the issues are structural and resource, and then part of the issues have just been this has been a new entity for all of us. So with that as a backdrop, I didn't mean to cut off Dr. Patel, but I'll ask her to chime in.
Dr. Greenberg, this is Dr. Ruth, and I actually am going to cut Dr. Patel off as well. I just wanted to jump in because what you said is a really good segue into a question we get asked a lot here at CDC. And it's also a question we're constantly asking ourselves, and that is, why hasn't CDC acknowledged that EBD68 is the cause of these AFM outbreaks, like others across the country have done, and when will we? So this is an important question to address, and I do want to say frankly that CDC is a conservative institution. We have a very high standard for declaring the cause of an outbreak, whether it be AFM or other outbreaks we investigate, like foodborne investigations that may have downstream implications and effects. That said, we do acknowledge, and I really hope this was visible in our recent vital signs MMWR, that enteroviruses, including EBD68, are leading candidates for the cause of this new AFM epidemiology that we've been seeing since 2014. Our research at CDC is really heavily focused on addressing some of the remaining questions we have about EBD68, and we're engaged with other academic colleagues to address some of these questions. We really like to pin down the association between EBD68 and the reported cases of AFM. Still, we do know that there are multiple viruses that cause AFM, and one question that remains is whether there's actually a single virus causing these outbreaks every other year, or whether there are multiple viruses. For example, just in 2018, we do know that there was another enterovirus, EBA71, that caused an outbreak in Colorado that did have AFM cases associated with it. So while we do focus on enteroviruses and EBD68 as the leading hypothesis, we want to keep other avenues of research open so as not to miss any cause.
Thanks, Janelle. And this is Manisha. And what I'd like to just add to that, though, is that, one of the biggest lessons we learned was that AFM was not like many of our nationally notifiable diseases, where we are primarily engaging with health departments, mainly for surveillance. And certainly we have partner organizations we liaise with and outreach activities to the public, but AFM is different. And this illness will require active involvement from public health and other federal agencies, but also academia, clinicians, and parents to move that needle forward. And it will take a village. And I don't think we were fast enough when with engaging with all the right partners from the beginning. And I particularly will say that we weren't fast enough with parents. And we know that they have a tremendous amount of knowledge about this illness because they're living with it every day. And so while there are certainly a number of challenges that we have with public health, there are certainly a lot of lessons that we have learned over the past couple of years on how we really actually do it. And it's going to take multiple people working together moving forward in providing all of their separate inputs, whether it's public health, whether it's basic science research, whether it's knowing sort of how to culturally be sensitive with families. All of that together is going to take a lot of effort, like Ben was saying, and a lot of activity engagement forward. And I'll just end with saying that we're all in. CDC is all in to sort of work on this really big issue.
Dr. Patel, thank you so much, and Dr. Routh as well, and Dr. Greenberg too, for that intro. I can certainly hear it, and I know that there is a commitment there, and that you've recognized where things haven't gone as they may have, and that we're committed to changing it and making things better and moving forward. So thank you so much. Moving forward into some of the questions we received for our community, we often hear about this being polio-like with AFM. And one of the first questions we received is, why is this not called polio? The 3 polio strains, and Dr. Routh, you had mentioned D68, A71, but also the Coxsackie virus are all in the same virus species and all have caused identical damage. Can you elaborate a little bit as to why it's not called polio?
Rebecca, this is Janell. Thank you so much. It's a great question, and I'm glad you asked. We were actually just discussing this very question with Dr. Priya Dugal yesterday. She's the geneticist from Johns Hopkins and was visiting us to talk through some of her work on AFM genetics. I think about this in 3 main ways. So 3 major reasons that we're not calling AFM polio, and we're trying to stay away from the words polio-like. The first reason is historic. The second has to do with cause. And then the third has to do with clinical presentation, which then leads to treatment and prevention. So you're correct in saying that both the disease caused by poliovirus and AFM share that same spinal cord lesion. The lesion is called poliomyelitis, and that's a combination of 2 Greek words, gray for polio, and marrow, that myelos means marrow. So taken together, poliomyelitis means an inflammation in the gray matter of the spinal cord, which is true of both AFM and of polio patients. However, in the historical context, poliomyelitis came to mean the disease associated with poliovirus. And this can be confusing because we know poliomyelitis caused by poliovirus has been eradicated from the United States. We test every stool sample from AFM patients submitted to us for poliovirus, and they've all tested negative. Secondly, we know that other viruses besides poliovirus can cause AFM. Like I just mentioned, non-polio enteroviruses and viruses like West Nile can have this same poliomyelitis clinical presentation. Therefore, we use the term AFM to encompass all of those different causes of those gray matter spinal lesions. And then finally, the disease caused by poliovirus and cases of AFM that we see in these peak even years, they do differ clinically. So while polio caused predominantly lower limb weakness, in AFM patients we see predominantly upper limb weakness. And this difference is important because I think it has implications for both medical and public health interventions. We're certainly learning through our network of clinical colleagues that early acute rehabilitation can be useful for AFM. And we also know that polio vaccination doesn't prevent AFM. So the distinctions in how we talk about it are incredibly important as we continue to learn more about the disease.
Thank you so much. I'm sorry.
If I can jump in there just to add to that, because we get this question all the time, and Janell's answer I think is perfect, but just to draw an analogy that people can use, on any given night in the emergency room, 2 patients could be admitted with trauma to their spine. One could be a gunshot and one could be a stabbing. They're both trauma to the spine, but we separate them out. And so even though the enteroviruses and polioviruses are in the same family of viruses, it is medically important to separate out the different ones because, as Janell said, what we do for patients and what we do in research for gunshots and stab wounds are different, and even though they each lead to the same trauma.
Great, thanks, Dr. Greenberg, for that as well. So moving on from the discussion about polio and the relationship to AFM, I'd like to jump to us talking about reporting and follow-up. So if we could talk a little bit about why reporting is not mandatory, what this means for AFM specifically.
So this is Manisha, and I'll jump in and maybe Janell can add, or Ben. I'm really curious to hear your thoughts in terms of notifiability and mandatory reporting. Let me just first start though by describing how the reporting flow works when you have a disease that's nationally notifiable. And so it kind of is in 4 segments. You have first the patient needs to present to the healthcare facility or provider. And then the provider needs to suspect the disease in that patient. And then the provider then would report that particular case to a health department or local health department, and then the health department reports to CDC. And so even though, and I don't know if many of you that are listening on this podcast have heard this already, but even though the proposal to make AFM nationally notifiable, it was not passed. It was not passed at the Council of State and Territorial Epidemiologists annual meeting that occurs in June every year. And one of the key reasons it didn't pass is because we currently don't have a confirmatory test for AFM, which is one of CDC's priority research areas. So even though it's not nationally notifiable, all states currently do have some type of requirement for clinicians for reporting cases with AFM. So either they explicitly say that the patient has AFM, or they may have provisions for reporting cases that have acute flaccid paralysis and no other apparent cause, or they have provisions that require reporting of, say, like a new or emerging condition of public health importance like AFM. So if we go back to the reporting flow I just described, one of the things that we did after 2016 was, after the 2016 outbreak, was to help build some additional infrastructure for health departments. And we called it the hybrid approach internally, and so that individual states could conduct case reviews and enlist neurologists in their own states to work alongside us and the neurology expert panel to confirm cases. And we felt this was really important because not only would it help increase knowledge and awareness of the health departments that we were working with directly, but there would be also some indirect effects because health departments would then be sort of armed with knowledge when they engage with their community providers. So even though AFM is not nationally notifiable right now, there's excellent bi-directional communication with health departments and CDC. So one of our main goals with the AFM program, when we look at where the gaps are in the reporting flow, is the strengthening of the frontline providers. So we obviously have neurologists and infectious disease physicians that may be more acutely aware, but we're talking about the pediatrician and the urgent care provider that a patient might present to. And so we do this by working with partner organizations like the American Academy of Pediatrics. There's also the Society for Pediatric Urgent Care. There's emergency rooms associations we work with. Having provider materials available on our website, like job aids on how to collect specimens properly, and then how to report those cases to health departments. And then one of our newest tools that we are partnering with TMA on is the 24/7 consultation service tool that is on the CDC website, and we also pushed it out through some of our communication channels, well, many of our communication channels. And maybe I could turn it over to Ben if you want to talk about that service and how it actually works and how it came to be.
Yeah, I'm happy to. And just before commenting on that, I just want to stress for all the listeners, one of the most critical portions of your answer that gets, I think, lost sometimes, and that is the Centers for Disease Control does not decide what is nationally a mandatory reportable condition. It is work with the Council of State and Territorial Epidemiologists. And so there's been a lot of feedback sent to the CDC on making this nationally reportable. And to be clear to everyone, I assumed the same 5 years ago. I assumed that Dr. Patel could sign a form and make something nationally reportable, and I had to be educated on the process, that it is this group of state and territorial epidemiologists. To that end, around reporting, just so families and parents know, what I have found is the CDC, our partners there, have been working diligently with us to see how could we make this nationally reportable, and if it's not, as it wasn't, passed by the Council of State and Territorial Epidemiologists, short of that, what can we do to make this work? I'm of the mindset that I want this reportable nationally. I think when we look at how reportable conditions occur in the United States, there's room for improvement in a lot of different ways. But since we have not succeeded in getting that group, the state and territorial epidemiologists, to support the proposal, as Dr. Patel said, we are trying to fill in the gaps and make sure every case gets counted. And what was referred to was a service that's being offered via a partnership via the TMA, our center here at UT Southwestern, and the Transverse Myelitis Center at Johns Hopkins, where now any clinician nationally can go online, fill out a very simple form, and within 24 hours get a real-time consultation with myself or Dr. Pardo at Hopkins or one of our TM experts at the centers, and support for both TM and specifically AFM. And as part of that process, we have it protocoled to remind clinicians that these numbers need to be reported to their state and local health departments and are there to prompt them. It is phenomenal that even with the amount of press and attention this has gotten, I'd say about half the time when I'm talking with clinicians around the country who have a possible case, they may not have yet reported it to public health officials. So Dr. Patel is right. Even if this became nationally reportable, we still have a long way to go to reminding our clinician colleagues when managing a case that they need to alert others for public health reasons.
Thank you, Dr. Greenberg and Dr. Patel. That is incredible information. I did not realize myself that it is not the CDC that makes this a nationally reportable disease. So to kind of elaborate on that a little bit more, how and do you anticipate that it ever would be something that would be mandatory to report? And for families that are advocating and continue to advocate for that, what suggestions are there, if you are aware, for them to reach those individuals who would make that decision?
Yeah, so I'm going to give an unofficial answer because I'm not sure in terms of my colleagues at CDC and about advocacy avenues around this, but as a person in the clinical trenches, what I would encourage families to do who feel that this should be reportable is take advantage of your representatives and your leaders. We have found partners in Congress who have been, frankly, moved by the personal stories of families. If I speak to members of Congress about needs for resources for research or public health, it only goes so far, because as we all know, we have a lot of needs in the country. When families engage with elected representatives, is much more impactful. And the TMA has worked hard to organize and work with TM and AFM families to help bridge that gap. And our AFM Parents Group has done an amazing job of integrating with Congress and trying to get advocacy there. That is one place where voices can be heard. Now, they have no mandate over the Council for State and Territorial Epidemiologists, but I'm willing to bet that if there's pushes for this coming from Congress, they have a say and a voice that would be meaningful. I am, other than finding who your state's representative is to the Council and sending them a letter or an email, making your thoughts heard, my understanding is that we would need to overhaul how the Council assesses what should be nationally reportable or not, and frankly, invest the resources. One of the factors in the decision for the Council is they're stretched very thin. Every time we add a nationally reportable condition, there is an investment that has to go with that. It's not a cost-free event. There's a significant amount of work that goes into it. And these are the same individuals who we are asking to monitor for bioterrorism. These are the same individuals who will get up at 3 a.m. on Christmas Eve because there's a suspected case of Ebola somewhere. These are the same individuals who are managing measles outbreaks across the country. And so we can't continue to ask our public health infrastructure to be perfect and do all things at all times if we're not willing to invest. And the people who have the most meaningful voices in setting that investment priority for the country are families that are affected. And so I encourage everybody to think broader than AFM and think about this purely from the public health perspective, and talk to congressional representatives about this is an area of infrastructure in the country that we never fully appreciate until we absolutely need it, and sometimes that's too late. And so we need to get vocal about pushing for resources to do this. If there were resources allotted, I actually think the Council may consider this differently, but that's just a guess on my part.
Thank you, Dr. Greenberg, for that. And I wanted to ask too, because I know it can sometimes become interchangeable or confused, but can you or one of the other physicians clarify the difference between what is mandatory reporting and what is nationally notifiable?
Yes, this is Manisha. I can do that. So there's nationally notifiability is basically a passive surveillance system. And so even diseases that we have that are eliminated in the US, like measles or polio, are nationally notifiable, but there's actually not any mandate to report these diseases even to CDC. The mandatory requirement, which requires state statutes and sort of the legal components of their sort of public health regulations, that's where the mandatory component actually comes into play. And so we actually, even with CDC, we use different language where providers are required to report to local health departments, and health departments then notify CDC. And Janelle, I don't know if you wanted to.
No, I think that sums it up well.
Great, thank you for that clarification. So moving on, I'd like for us to discuss about follow-up specifically. So does the CDC currently or state health departments follow up with all patients? Or, you know, if they do, how long does this follow-up occur for?
Gigi, thanks. This is Janelle, and I'll take that question. So, you know, first I'll say that I think this is an area that we could have done better in previous years. Long-term outcomes of AFM patients are incredibly important for our understanding of this disease, and I think we recognized that last year we needed to be doing more to really understand long-term outcomes across our national confirmed cases. So we have implemented a long-term follow-up project. We are now interviewing all confirmed and probable cases from 2018 with a standardized questionnaire to be able to track outcome measures over time. These outcome measures are going to be collected at 2 months, 6 months, and 12 months post limb weakness onset. Right now, we're starting with the 2018 cases. I think, you know, and Ben can correct me if I'm wrong, but there are a lot of changes that do take place from onset of limb weakness through that first year of follow-up, and we would like to understand that better. I think based on the results and the data that we receive from these interviews, we may decide to look back further. One other thing that we are doing is partnering with the National Institutes of Health, and again, Ben can elaborate on this, to conduct a natural history study. This will be a prospective study moving forward. It's scheduled to start in the fall of this year, that will enroll patients with limb weakness onset, and that study will follow them very specifically, both with clinical examinations and neurologic examinations for 12 months after their illness begins. So we're hoping that that combination, both that natural history study and then our larger overall outcomes with our national AFM group, will help us understand a little bit better what those outcomes are.
And so if I may just chime in there, so the efforts around outcomes are definitely picking up speed, but to the members of the TMA and our AFM community, at this state, what we're happy to see the increased data collection around outcomes, but they are still limited in terms of time frame. And as a clinician in the field, what we really want to see ultimately are the 2, 3, 4, 5, 6 year outcomes for several reasons. One is to get rid of the myth that people can't or don't recover. We are seeing very slow but meaningful recoveries 2, 3, 4, 5 years out. And anecdotally, I feel it's related to the level of intensity of rehabilitation that goes on, but I can't prove that statement yet until we collect the data. And we had submitted a grant request to the NIH for a long-term outcome study and got notified yesterday, unfortunately, that we were not being funded for it. The longitudinal study that is launching is still looking at shorter-term outcomes, a year, and this is a major gap in our data right now, and frankly, this is where the TMA comes in, and we're going to be relying on the community and the partnership with the TMA to help with not just data collection, but with raising the funds to appropriately do data collection across the hundreds of families who have been affected by this relative to outcomes and long-term treatments that they have had access to, so we can correlate outcomes with what people are doing. And so as we're trying to raise the resources to do this, right now we're still stuck with shorter-term outcomes. But we'd love to prove to the world that with interventions, our kiddos can continue to make progress.
Thank you again for that information. I'd like to move on and ask a question about the recent MMWR that was published and the statistics on that report. It had been questioned that there were 231 spine MRIs that were performed on confirmed cases, yet there were 233 that were confirmed. I believe that has changed, but I just want to clarify that with Dr. Routh or Dr. Patel, and also ask about the definitive criteria that is used by the CDC to confirm these cases.
Rebecca, thanks. This is Janell, and I can clarify that. It just goes to show no matter how often you look over your data, sometimes you miss something, and that indeed was an error in the table. When we went back and looked to see what cases those two were that did not have spinal MRIs conducted, we actually found that they did, and that it just was an error in data entry. So we are now reporting that all confirmed cases did have a spinal MRI performed, 233 out of 233, and that erratum will be published by MMWR on August 9th. So the table will be corrected and a new manuscript will be published on August 9th. So thanks for that question and giving us the opportunity to correct that over the podcast. You also mentioned the CDC case definition, and I did want to take some time with this question because it's a good one, and it is actually one of the reasons we wanted to do this podcast in the first place. I think there is a lot of confusion between CDC's surveillance case classification and a diagnosis of AFM by the clinical team. And so I'd like to explain how I see that difference, and then either Manisha or Ben would love to hear your thoughts as well. So first and foremost, we know that AFM is a spectrum of clinical illness. I think all of us would agree that some children have a greater degree of paralysis than others, and we see really a full spectrum. It is incredibly important for clinicians to recognize AFM across that entire spectrum and get patients into care quickly. We never want to discount a case of AFM. It's incredibly important for us that AFM is recognized by those, early clinicians. Patients get hospitalized, respiratory status gets monitored, because we do know patients can decompensate quite quickly, particularly in their respiratory status. So the diagnosis of AFM should be made quickly, and it should be made in conjunction both with the clinical team and experts in the field, such as neurologists and infectious disease docs, as well as now this new TMA 24-hour consultation that has been alluded to already. It's important to have that diagnosis made so that medical management can be initiated, including, as I've said before, that acute rehabilitation. Surveillance case classification, on the other hand, is a much different entity. It takes much longer. I think, as many of you know, it can take weeks to months to get that case classification back. And that's because the purpose of surveillance is really different than the purpose of diagnosis. We need a standardized case definition to compare trends across years and trends across different states. And the challenge of creating a case definition for AFM is that we don't have a simple diagnostic test. It would be great if every patient came to us with an MRI showing a clear anterior horn cell lesion that would be diagnostic of AFM, but we don't. That just doesn't happen. So instead, we created a surveillance case definition unique enough to count AFM cases, but also not broad enough to include things that are not AFM, like transverse myelitis. Each case, the medical records and images for each patient are reviewed by a panel of neurologic experts, and even they have difficulty sometimes distinguishing AFM from these other illnesses. And so you're correct, and parents, that say, well, my child wasn't counted in the CDC surveillance case definition, you're correct that right now our case definition is strict. It may not capture all cases of AFM at this time, but for us, it's really necessary to use this clear definition for standardization and to help us understand more about the risk factors and causes of AFM. As we learn more, we'll definitely revise and revisit that case definition just like we did this year, making modifications hopefully down the road to be more inclusive. But one goal I think that we really have, and that was one of the reasons to put out the vital signs, was to make sure that clinicians know that our surveillance case classification is not a substitute for diagnosis, nor should it change the diagnosis. And we want to continue to emphasize that point with clinicians moving forward.
Yeah, that's right. This is Manisha, and I just wanted to add that just in general with case definitions, if you look at, you can find this on the web, looking at different nationally notifiable diseases, that case definitions are purposefully kept simple. And that's so that providers across a vast array of expertise know who they should report. And so if they see a patient meeting simple criteria, they would make sure that they're contacting their health departments. Now, on the flip side, we know that patients, and I say patients, not cases, which is the word we use for surveillance, but patients with AFM are complex, and they have different presentations, different test results, recovery periods, and degrees of paralysis. So kind of what Dr. Ruth was referring to is that it really should not be superseding the diagnosis, and the ultimate aim is to make sure patients are managed quickly and with the best medical care they can, but that we're able to capture trends across time so we can identify risk factors. And I think that some of the accumulation of data that we've had since we started surveillance in 2014 has been incredibly instructive, including revising the case definition, identifying risk factors, knowing where gaps in our knowledge base are from a public health perspective.
Manisha, and I'll add one more thing to that. I did have a conversation, a very heartfelt conversation with a parent the other day who talked about CDC undercounting AFM. And I absolutely agree that I think we can do a better job when we publish our surveillance numbers and when we talk about our surveillance numbers to put those into context. So I think that's something that the call is very instructive. I think I learned a lot from our conversation, and that's something that we'll really consider moving forward.
Great, thank you for that. And then you talked a little bit about, the transverse myelitis and differentiating between AFM and transverse myelitis. But what if a case involves both gray and white matter? How are these cases classified? Are they both AFM and TM, or just one or the other? And this might be a question also for Dr. Greenberg as well.
I was just going to say, this is Janell. Yeah. Dr. Greenberg, take it away.
Yeah, so the way the definition is written, and frankly, the way we operationalize things clinically, at least I can speak to my center, and I'd say the majority of centers I work with, is if there is a predominance of gray matter involvement, it'll be classified as AFM. And what we're seeing in our data from the CAPTURE study and what we've seen just clinically is if you take the definition where a child has a flaccid limb, gray matter involvement, and you don't use anything else to exclude patients, it can be up to a half of patients who have some level of significant white matter involvement. And so those are included. They get reported as AFM. What's interesting about this, just scientifically, is if you look back to old literature on the polio virus causing gray matter damage in the spinal cord, and this predates MRIs. This goes back to the 1930s, 1940s, 1950s. There were a significant percent of poliomyelitis patients who would have some evidence of white matter involvement. And so when a virus, if this is a virus infecting the gray matter of the cord, it's not unusual for there to be secondary damage to the white matter. And that's a theory we're operating under, at least at our center. I'm not speaking for a national organization at this point. But if they have flaccid weakness and they have predominant gray matter involvement, they would be AFM, irregardless of how much white matter there is.
Thank you, Dr. Greenberg. Really appreciate that. A couple of questions that have come up from families is their concern about how the CDC discusses recovery in children with AFM, often making it seem like recovery is better for them when there are still so many kids who are fully paralyzed and vent dependent and not really paying as much or seeming to pay as much attention to the respiratory distress that is associated with AFM. Would either Dr. Routh or Dr. Patel like to comment on that at all?
And actually, if I can chime in just before them, I hate cutting them off, but I just want to point out just one aspect to this that's important to keep in mind. From where I sit on the clinical side, there is an extraordinary spectrum of injury and recovery. And frankly speaking, there's an interesting phenomenon. We've seen this in other conditions where individuals and families of individuals who are more severely affected, and this would make sense, tend to take advantage of, not take advantage, take part in community-based resources, support groups, organizations, the TMA, AFM Parents Group, etc. And for families where kids had a milder case and recovered and have little to no deficits and are going on, it's kind of a bad dream and it's past them and they've moved on. And so if we look at within social media organizations that are supporting families in need very appropriately, I think we get a little bit of a skewed view in severity. I think it's more often very severe than not, but it doesn't take into account the fact that there are patients who are recovering that may not be as vocal or as visible. And so when we work on language about recovery, and this isn't necessarily just a CDC issue, I take ownership of this because I'm speaking about this and we're writing about this. There is a spectrum. There are absolutely just heartbreaking and gut-wrenching cases of children who have been devastated by this condition with significant impacts on respiratory status, motor status, swallowing status, and it is a huge area of need where we need an investment to improve our outcomes for every child. But when we talk about the language that's being used nationally as kind of talking about this spectrum, it's not to take away from the significant number of children who have had just devastating events from this condition. It's meant to recognize the fact that there are milder cases. And the reason that's there is not just about recognition and science. It's also, frankly, around making sure clinicians keep their eyes open for it, even in children with mild weakness. We've had some cases, and I know Dr. Pardo has had some cases, where children were diagnosed with pinched nerves or very mild musculoskeletal issues, and for a variety of processes later we found out, no, they actually had a mild version of AFM. And if we're going to solve this issue from a public health perspective, epidemiologic perspective, virology perspective, we need to know all cases, mild and severe. And so I'll be quiet now and let my colleagues at CDC speak to this, but it's factually correct that there is a spectrum of cases.
Ben, thanks so much. This is Janell, and I think everything you said captured the point perfectly, but I definitely do want to say on behalf of the AFM team here at CDC, we never, ever want to minimize the seriousness or severity of AFM. I think that's been one wonderful thing about our relationship with the Parents Association, is being able to hear the stories and learn firsthand about families' experiences with AFM. I've also been very lucky, both in 2016 and just recently in 2019, have had the opportunity to go do some interviews with families and absolutely have seen the firsthand effects of that continued paralysis and need for respiratory support on the family dynamic. Yes, we do know from our 2018 data that was published in the MMWR, about 27% of children do suffer some respiratory distress with their illness, and the majority of those do require mechanical ventilation. So this is not, this is not minimal. This is definitely invasive procedures to help children breathe. One thing that we are doing to try to understand risk factors for that severe type of illness is to do these interviews with our 2018 patients and their families to really understand their seeking of medical care and what they went through in the hospital. Again, all of the other questions that we tend to ask about risk factors to really try to understand this more fully. Thanks.
Thank you both, Dr. Routh and Dr. Greenberg, for those very thoughtful responses. I know it is not easy to have to look at so much and so much severity in some of our children as well. So I sincerely appreciate again your thoughtful responses. It kind of leads into another question that has been arising, and why we're generally only referring to it as limb weakness and not paralysis when it comes to AFM symptoms. Is there a particular reason why it's being categorized as limb weakness, or watching for limb weakness versus paralysis?
Yeah, I'm going to jump in on that one because it's for a very specific reason, and it's not to make it sound milder than it is. It's specifically around making sure clinicians and parents recognize even the mildest of cases or the early symptoms. So limb weakness includes paralysis. So paralysis is the most severe limb weakness. But if we only use the term paralysis, then there are a lot of kids with AFM who had weakness but not to the stage of paralysis who might not get recognized or counted. And so it's a clinically and scientifically accurate term. It is not meant to cast an aspersion around how mild or severe the condition is. It's there to raise awareness to catch cases early.
Thank you. That's very helpful. I know that it's always good to hear the clinical side of things and where that is coming from. So thank you for that clarification. Another question about treatments and symptoms. Obviously, we are urging that when these symptoms are presented that they get treatment ASAP. Is there research being done or data being collected by the CDC about the treatments that work to stop the damage being done in the acute phase of AFM? I don't know, Dr. Greenberg, if you'd like to speak to that.
So I can speak to the non-CDC efforts, and I'm aware of the CDC efforts, and they are there. We both, our group with the CAPTURE study and the CDC through the voluntary reporting system and then their tracking of cases and data collection of cases, we are all collecting data on what therapies were provided to patients because there is not a clear guide yet on how to select patients for different therapies. So we're just collecting the data of what patients are getting and then constantly looking at it as the data set grows to look for any patterns. We'll be putting out a publication this year in terms of our experience around different therapies, but it's obviously smaller numbers in the whole cohort nationally. And I know this has been a priority for the CDC to collect data on who got corticosteroids, who got plasmapheresis, who got IVIG, who got a variety of other things, and then determine whether or not therapies seem to be doing help or harm. I will, before turning things over, just state for everyone, these are incredibly difficult data sets to understand. because these are retrospective studies. And so the people getting certain therapies at my center may be getting them because they saw me, and people getting therapy with, I'll say Carlos Pardo because he's a good friend and he does a wonderful job. He may have a slightly different take on things. And so how you compare data sets is extremely difficult and fraught with risk. And so we're trying to be very cautious to not over-interpret our data relative to response to therapy. I have my biases, and I admit my biases around therapeutic interventions. The CDC appropriately is taking a non-biased approach. They're there to keep me honest and take an agnostic approach to collecting all the data and seeing where the statistics lie. But it's been a priority for us as a center, and from my understanding for my colleagues at the CDC as well. But I'll let Manisha and Janell comment.
Ben, thanks. I appreciate you highlighting the difficulties with this type of data collection. You're right. We do request medical records on every patient that is reported as a suspected case of AFM to CDC, and we do a thorough chart abstraction of that medical information. And that chart abstraction contains questions about what treatments patients received, the duration of the treatments, et cetera. Again, for us, it's been difficult to link any treatment to outcomes because of the reasons Ben talked about. There's just a lot of heterogeneity in the way treatments are given, the way neurologic exams are conducted, and so it's hard to make any strong conclusions. One thing that we are doing with our academic colleagues across the United States is we formed a work group to work on some clinical considerations for AFM. And part of this work group is to look at the literature every year and to just liaise with each other to see if anything new is coming out in terms of treatment for AFM. Those considerations are published on the web at this time. We don't really recommend for or against any of the current treatments that are being used for AFM, but certainly if anything were to change, again, we have now, I think, a more robust network of clinicians that talk to each other on a fairly regular basis. If something was to change, we would hear about that and update those considerations right away.
Great, thank you. And as we're getting to the end of our time, I just wanted to talk a bit about the 7 hospitals in the surveillance, enhanced AFM surveillance. How do these hospitals work with the public, with the CDC? Are these hospitals where treatment should be sought? And are cases more likely to be reported if someone's treated at these hospitals? Dr. Ruth or Dr. Patel?
Yeah, this is Dr. Manisha, and I can take that question. So one of our key questions is, how does local circulation of enteroviruses affect risk of AFM for that community? So for instance, say if we had increased EBD68 activity in Atlanta, does that mean there would be increased cases of AFM in Atlanta as well? And we know that's what happened in 2014 and 2018 nationally, where there was increased EBD68 associated respiratory illnesses that were correlating with our AFM outbreaks. But we also had reports from more localized areas showing that they would have increased EBD68 activity, but for example, no AFM cases. And so we wanted to better understand this and what the risk was and what that correlation between enteroviruses and AFM would be. So the 7 pediatric hospitals are part of CDC's new vaccine surveillance network, NVSN, and if you actually Google CDC and NVSN, you can find a list of the 7 institutions that are involved in that. And these 7 sites have been active and operating for almost 10 years, and they've received funding from CDC to conduct active surveillance for gastrointestinal as well as respiratory illnesses. And we will now conduct enhanced AFM surveillance at those sites as well. So these sites were specifically chosen for their capacity to do active viral surveillance. But I also want to say there are other institutions that conduct strong viral surveillance as well that are not part of NVSN. And the NBSN sites all have experienced clinicians and are excellent places to receive care, but they are just a small number of the many hospitals that around the country that are providing excellent care and expertise to AFM patients.
And I'll just jump in and quickly say, I hope that cases are not more likely to be reported from one of those 7 hospitals. Really, one thing that we've really tried to emphasize in the last month is early recognition of AFM and reporting. That has gone out over our vital signs blast, and we are going to continue to work on that in the coming months. Our communications office has made contact with over 23 different professional organizations around the United States, and we are going to continue to work with them to make sure that every case gets reported to the health department.
Thank you, Dr. Patel and Dr. Routh, for giving us some additional information on those sites. We're actually at our hour mark now, and we certainly want to respect your time and schedules. But before we formally end our podcast today, is there anything that either one of the 3 of you would like to add? Unfortunately, we're not able to get to all of the questions we had submitted, but we'd love to hear any additional bits of information or anything you'd like to share with us before we wrap it up.
I'll chime in and just say thank you to the TMA for hosting this, my colleagues at the CDC for taking part. I hope our listeners recognize what a unique event this is to have our partners at the CDC taking time out for public education in collaboration with a nonprofit patient advocacy group. We are very appreciative of their time. And I'll also remind our family members that often you hear about cases before anybody else through Facebook, Twitter, friends. You get contacted. If you hear about cases, you have a role to play in public health. Have those individuals who are hospitalized instruct their clinicians to reach out, either through the TMA and the consultation line or through state and local health departments. You have a very strong voice and power to make sure these cases get reported, get followed, and kids get the care they need. So we're looking to partner up with all of you to make sure this happens as well as it can.
Thanks, Ben. This is Janell, and I just, again, wanted to give a real word of thanks to both the TMA, Gigi, and Rebecca. You both have been wonderful helping us organize this podcast. This was a real opportunity for us to connect to our primary audience, which is really the public and parents of children affected by AFM. And so we are just really thankful for the opportunity to speak frankly about the work that we do.
Thank you. Thank you all so much for joining us today. We really appreciate it and look forward to continuing the conversation in the future. Thank you.
Thank you.
Thank you.
Thank you all. Bye.